Now, coming to the topic of this morning, it is a hot topic because obviously there are different opinions. We will hear from a distinguished panel what they feel should be done for a patient that might need combined surgery, or whether they do one single procedure or whether they divide that into different steps. Will the panel please introduce themselves?
I'm Dr. Matteo Forlini from Italy and San Marino.
Hello, I am Laura Sararols. I am from Spain, from Barcelona.
My name is Alejandro Lavaque. I come from South America, from Argentina, and I am very pleased to be here with all of you guys.
I'm Dr. Vaibhav Sethi from Gurugram, Haryana, India, and I'm proud to be here with all my fellow colleagues.
So, when we talk about combined surgery, pros and cons, actually it's a very vast topic, isn't it? Because we could be discussing vitreoretinal surgery with cataract surgery in a patient that may need cataract surgery or may not need cataract surgery, but you know that the vitreoretinal procedure will eventually determine a cataract. So do you do that before the cataract actually develops? It could also include other procedures, for example, glaucoma surgery. So we're talking about elective procedures, obviously not procedures in which you need to do something in order to obtain a certain result. So I would start with cataract surgery. Pros, yes or no, combined, yes or no, because that is probably the most frequent condition in which we find our patients. So may I have your views on what you would do with in a patient that actually has the need for macular surgery but does not have a cataract which impedes you from seeing what you're doing. So it's a relatively clear cornea or a clear cornea. What would you do?
In my opinion, I am pro combined phaco-vitrectomy. In my experience, if the age of the patient is from 50 years old on, for sure I would choose phaco and vitrectomy altogether. The only reason not to do that is a young patient, to save the lens. But also we have to remember that macular surgery most of the time are not young patients. It's rare. So usually we are thinking about macular pucker, macular hole, diabetic, tractional edema. So most of patients are over 50. So except the young patients, in that case I want to save the lens, so I just do vitrectomy, no phaco. In the other cases I prefer phaco-vitrectomy. Why? Because the patient comes only one time in operating room. I can also see better because if I immediately do the phaco, I put the lens IOL, so I can see perfectly the fundus. And I don't have the deep depth of the crystalline lens, so with my vitrectomy, I feel very comfortable. Safer. Mm-hmm. Also, I don't want to say, but if I have complications with the cataract surgery, like if I break the capsule, I hope not.
You're in the eye already.
I already there with my trocars.
Yes.
Because the first thing, I put the trocars. So I put the trocars, I do the phaco, and then completely tattoo.
I'm also pro doing that, and also the age. I would say over 45 years old, I always offer the option of doing a combined. Evidently, the patient only takes the risk of going to surgery once. And also, I think that if you don't do a combined and the patient has the cataract later on, it's not going to be you, it's going to be the surgery. It's going to be a normal phaco surgeon, and he might have complications because that eye has no vitreous, and the surgery is a little bit more complicated. Also, there's also more risk of cystoid macular edema during the phaco later, if it was a patient with a macular pucker, for example. So I would strongly recommend.
So here we have the pros and the reasons we can understand. So we're talking about a clear lens, patients that are over 50, so you're not in any way affecting their accommodation, and you are for removing the lens, the clear lens. We're not talking about cataract, the clear lens, because you know that the patient is going to develop a cataract eventually, and you feel that by doing the cataract procedure preemptively, you will be getting some advantages. Patient will not be coming back to the operating room. You can manage eventual complications that you have with the cataract surgery, and also you think that it's safer because the cataract surgery, which would be done after, would be done by a non-vitreoretinal surgeon, which may complicate things because he's not prepared to deal with a more
vitrectomized eye.
difficult vitrectomized eye. Obviously, you are the cons. So why?
Okay, I have several questions that I would like to ask to my fellow partners. First of all, when you, because I'm probably not 100% against the combination, but I do prefer to do it sequentially. For instance, when you combine cataract surgery with vitrectomy, you rather prefer a complete vitrectomy, 100% vitrectomy, for instance, when you have only a macular pucker, or you do localized vitrectomy and remove the pucker, because this is an issue. If you already invade the anterior segment and you plan to perform a complete vitrectomy, and I'm meaning a 360 vitrectomy addressing the whole vitreous base, you have an unstable anterior chamber. And I would like to know if you put, for instance, a stitch in the main cataract incision, and I also would like to know how big you place your capsulorhexis in order to get an stable intraocular lens.
So what Alejandro is saying is that essentially, how do you keep that anterior chamber closed? I think we all use hydrosuture. I don't think any of you put sutures, or do you put sutures?
No suture.
No suture.
No suture, and the capsulorhexis quite small, around 5 or 5.2 millimeters. Important that the rexis is smaller than the optic plate, so
Yes.
the IOL is stable.
Laura?
I do use suture because I do not like to do the hydro
Okay.
in the stroma because it difficults the visualization. So I put a suture and then I take it away when I finish the phaco-vitrectomy.
How complete will be your vitrectomy?
For macular surgery, like macular pucker or macular hole, no complete, only core vitrectomy and a little enlarged to the mid-periphery without indentation. So the rest of the vitreous, in an anterior vitreous, are still there.
Laura?
I do it quite complete, but not as complete or as when you do a retinal detachment, for example, or if I don't see anything in the peripheral retina, I will go for the vitreous, but not as complete. But it does allow you to have a stable anterior chamber.
Vaibhav, what do you think?
Yes,
You're against? Why?
less is more. We've been taught in surgery. What I mean to say is we have a clear lens here. We have a macular pucker, we have a macular hole. The reason for the vision being down is a macular problem. The problem is the retina. We are doing something extra which is not required to be done. We're not 100% sure we can do a perfect phacoemulsification and placing the IOL in the bag. By doing a clear lens extraction and placing a lens in the eye, you might have a complication. We are humans after all. And that will complicate your surgery. So why don't we just treat the macular pucker, do your best. You don't require complete vitrectomy as we have discussed. We need to treat the problem. And after treating the problem, we go back safe and we tackle the cataract as it comes at a second sitting when the patient really needs it. So we have that option. The patient has the option of putting a good lens in the eye, which he can choose with a better biometry. Thank you.
Yes, well, I can see both your points of view, but what if the lens is not perfectly clear? So you know there is a bit of cataract there already, and you're going to be doing the cataract surgery sooner or later. It's just a question of time. So would you still have the same attitude? Would you still do let's say if you think you're going to be doing the cataract surgery within a few months, within a couple of years, will you still be doing two different procedures, or would you combine the two?
I would still be doing two separate procedures in the sense that I might give the patient some time to have, at least to know how much vision the patient is improving on with the retinal problem being solved, and then take up the cataract surgery at a second date.
Alejandro, same?
Same thing, but I would like to add something more, which is important also because we really want to do the best for the patient. And if you separate both procedures, you will have the certainty that the patient is understanding both procedures. So I think it is too much for the patient to consider everything, the variable that you have to have in mind during the macular surgery, but also cataract surgery. So in order to be totally clear with the patient, we have to have not only two separate procedures, but also two separate conversations with the patient, because they are two totally different words. So if I put in the shoes of the patient, for me it will be too difficult to understand all the concepts that I need to know to have a precise decision.
The other consideration is a very practical, scientific consideration, is that you don't know how much of the surgery, of the improvement is due to one surgery and how much is due to the other. But you may find that you want to do a cataract first, see what the vision is like in that patient, and if that patient is happy, even if it's not 20/20, then you can say, well, you know, if you're happy, you don't have metamorphopsia, you have a pucker which is flat, doesn't affect you that much, maybe you don't want to go through a vitrectomy which exposes you to greater risks. So this, I think, is something which can be considered if you are for the two different procedures. But then you would invert the order and you would do cataract first and then decide whether you want to do vitrectomy after.
There's probably another important issue. It's happened in Argentina, and I'm totally sure that it's happened also in Europe and also in India. When the patient in Argentina goes through a cataract procedure, they are assuming that the vision will be perfect. It doesn't matter what you explain to the patient before surgery. They want a perfect vision, and perfect vision means to see far away and also to see close. So if you combine the procedure, you confuse the patient.
Which leads to another question. So let's suppose that you are doing a combined procedure. What lens do you implant? Do you go for a standard lens because you assume that your IOL calculations are not precise or they may change after the macular surgery? Or do you go for a premium lens, such as EDOF lens? And does anybody of you still use a trifocal? And would you be willing to implant a trifocal in an eye which has had a vitrectomy and could theoretically have problems deriving from that?
I think that if you do the combined and you're doing a clear lens, you have to be able to offer a premium lens. And I think that we've done a study with the EDOF lenses, with the Vivity, and the results were really good. So now I am confident in being able to offer an EDOF lens. With that, they have the advantage of the refractive. The biometry is correct. You don't have any refractive errors. And if you position the lens correctly, you can use a toric lens. And if the prognosis of the epiretinal membrane is good, the patient will be very happy with that lens.
I would add that EDOF lenses today have a certain margin so that the biometry sometimes is forgiving. So if you don't really get the biometry right, there is that half a diopter which you can play on because the EDOF lenses are very forgiving. Now, you've brought up the toric lens issue, and I totally agree. I also implant toric lenses. But when during the procedure do you implant? At the beginning or at the end?
I put it at the beginning. I do the phaco, I put the lens, I place the toric according to the Varion. It shows me where to leave it. But at the end of the
You check.
vitrectomy, I check. And usually it hasn't moved,
Okay.
but I do check.
Okay, you do.
Same approach, the lens at the beginning and I check at the end. But about the multifocality or head-off, it depends on the age. Because if the patient is quite old, like 70, probably I will do phaco in the other eye. So I can coordinate two head-off lenses or two trifocal lenses. But if the patient is like 50 years old, I operate one eye because of the macular pucker and phaco. But probably the other eye, no. Maybe it will receive phaco in 20 years. So in that case, I do only lens monofocal, toric if there is astigmatism, but only monofocal. And in the future, when he will be 70 years old, doing the other phaco, maybe I can put the add-on IOL, like piggyback, if the patient requires it, but usually monofocal.
Why would you do that? You feel that having an EDOF on one eye and
Exactly.
and their own lens in the other eye doesn't work?
The expectation of the patient. Also, in my case, also for economic reason, because private patients paying, of course, expensive multifocal or head-off, but I don't know. I know that the result is poor, so the patient pays more, but doesn't see better because it's not coordinated the two eyes.
And you? What would you do?
My go-to lens for retinal surgery is a monofocal lens.
Monofocal.
And the other scenario in toric lenses that as I face and we all face is we have another component of the gas at the back or the air. Now, post-surgery, we might have placed the toric lens in proper alignment, but post-surgery with positioning and the gas expanding or with the air pushing it, there are good chances the lens can rotate and the patient can develop an astigmatism. So those are certain factors which always play in my mind when I go for a surgery.
So perhaps what you're saying here is that we can implant a toric lens, but the toric lens may be implanted in patients that do not need gas tamponade, but gas which needs positioning, let's say even for a day or 2 days for a macular hole, then you feel that that could affect the rotation of the toric lens, correct?
Yes.
So you would not put in a toric lens.
So that's why my argument comes in, I will do the surgery on a separate setting.
Okay, right. Alejandro.
I agree with my partner. If I had to perform combined, I will say toric yes, EDOF yes, and I feel confident with the retina platform. So that gives us an advantage. Before surgery, I will check which is the dominant and the non-dominant eye, because I feel confident implanting an EDOF in the dominant eye, and mostly if it is the dominant eye, the eye with the macular problem, and if the other eye, it doesn't have a macular problem, I go by a trifocal lens there, but always sequentially. So I'm totally agree with you.
I like to give the patient the opportunity of using an EDOF because I think that, anyway, the vision will benefit if we've done a good job on the macula, and obviously the damage to the macula has not been extensive preoperatively, then they will benefit from the use of an EDOF. Definitely, a toric lens is also in the cards because it will give the patient quite an advantage. I'm not too sure about trifocal lenses because obviously they do have all the drawbacks that we know. So at the moment, I have gone out of trifocal lenses because of the glare and everything else. So I would not go for that.
I remember that for some lenses, the macular disorders are contraindications. Usually, many lenses say that you need a perfect macula for a good functioning.
Yeah.
Just to be clear, if the macular problem is in only one eye, in that eye I will pick an EDOF, and if the contralateral eye, the macular is okay, I will feel confident implanting a trifocal there.
Mix
and
and
combine,
match.
mix and match, exactly.
So we've talked about macular pathologies. We will not go into more complex questions such as the use of capsular tension rings or the incidence of posterior capsule rupture. But there is one question, because it is becoming more common for patients to ask for floaterectomy, so the removal of floaters. How many of you agree to that? How many of you do floaterectomy? Do you do floaterectomy?
No.
Do you?
Yes.
No in young patients, but after 50
Well,
years,
obviously, yes. And you?
In general, no.
Okay.
Very few patients.
Very few patients, okay. So what makes you decide whether you're going to be doing floaterectomy on a patient or not? You say very few, why? What is your watershed, your cutoff? Why do you say because you like them and you don't like them, or is it a more serious reason?
I think the patient has to understand that he's assuming a risk,
Yes.
and that risk is there.
Yes.
And I think sometimes you explain the risk to the patient, then the patient changes his opinion. But sometimes you explain the risk and the patient does not change the opinion, especially if it's had a retina surgery in the other eye.
Yes.
So
In that case,
In
you
that
would
case,
give, okay, floaterectomy. Okay, and if you're doing floaterectomy, what do? You obviously do not do sequential, or do you do sequential?
No cataract?
No cataract.
Then only the floaters.
Only the floaters.
Me either, only the floaters. But it happens frequently that we see a patient with mild cataract, but the patient feels that there's something that is not good in the vision, and what is not good is the presence of floaters. So you have to ask very carefully the patient and try to identify where the problem is. Because if you operate on the cataract and leave the floater behind, the patient won't be happy with you.
Okay.
Be concerned with that.
And what would you do? Obviously, not sequential, but at the same time, yes? So you would do...
same time, but really the age
Okay,
of the patient.
age we all agree on.
Because another point of view that we didn't say, the myopic patient. I mean, if high myopia, if I decide to operate one eye, and maybe the cataract will develop, so I have to do cataract, then the patient will have a big anisometropia. So then you have to operate the other eye. So you start moving a lot of things. So in very myopic patients, more and more conservative.
also highly myopic patients have more risk for retinal detachments in the future or pathologic adhesions of the vitreous. So I would
So
be very
you
careful.
will be surprised that I think it's your common experience that actually the myopic patients are the ones that have the largest floaters. They have huge strands of vitreous and they don't complain. Those are the patients that don't complain. The patients that complain are the ones that have fewer floaters, but they have good eyesight, and therefore the floaters do affect them. These patients, obviously, what sort of lenses do we implant? I think you have to give the patient the best possible lens, because these are difficult patients. Otherwise, they would not ask for floaterectomy. These patients are psychologically different from the rest. They will not settle for anything less than perfection. So you have to give them EDOF lenses, I think, in these cases. Do you agree?
These patients, as you said, are very precise and they know what they want. And so if you need to be placing them with good lenses, but if you place them in a trifocal lens, it could sometimes land them in trouble because that little glare that you accept would be an issue for them the rest of their life.
Yes, I think trifocal lenses will probably be on the way out because of we are all a bit frightened because it's unpredictable whether the patient will be happy, will adapt, or will not adapt to the glares, which are not present only at night, they're also present in the day. And therefore the patient may not be happy, especially in these very difficult, psychologically difficult patients.
I remember a patient, young patient, wearing a T-shirt in Italy written, "I don't ask solutions, I just want to complain."
And with that, so summing up, Do we have a question from the audience? I see a lot of people out there. A raise of hands. Yes.
I think the point I want to make is I'm actually pro non-combined surgery. I think epiretinal membrane surgery in non-myopic lends itself well to combine because you don't use gas. And maybe other cases to consider combined, at least consider them. If you have a long surgery, like a diabetic or a PVR, the lens may go fogged during the surgery. So I think in these circumstances, at least be prepared. You have calculations and you have a combined pack for cataract vitrectomy.
Yes, I think you're absolutely right. Totally agree. We know we need to put a tube into the eye.
Yes.
Do we do it at the same time? Do we put a valve at the same time? So we all do more complex surgeries where we do more than one procedure. Let's say you have neovascular glaucoma and you do the cataract because you can't see what you're doing. You approach the retina, fix the retina, and then maybe because you have the neovascular glaucoma, you put in a valve as well. Do we do all that together? Sometimes yes, sometimes no. Depends from your skill set, it depends from circumstances, it depends from the patient.
Epiretinal membrane surgery lends itself better than macular hole.
Yes.
And in a study we did, we found threefold increase in IOL surgery, second IOL surgery for decentration in surgery other than epiretinal membrane. And I think the reason is short surgery, quick surgery, and you usually don't need a tamponade.
Exactly. Well, thank you very much. Any final comments to add?
Yes, and just finally, I'd like to just ask the house this one interesting scenario. Your family member, nuclear sclerosis, cortical cataract, and a macular hole. What surgery will you do and what lens will you place? Dr. Matteo.
Combined surgery because I'm at this table. No, I'm joking. I really do combined surgery with macular hole. You said macular hole. I still believe monofocal because I think that after macular hole, even if you close the hole, I don't think that premium IOL will work. In my opinion, sometimes you can put monofocal and maybe later add on for the multifocal if the patient requires.
Alejandro?
If it is a macular hole, I will place an EDOF, Rainer A and B, because it's pretty similar to a monofocal, and you get the patient the chance to get something more.
Laura?
If the macular hole is small and the prognostic is for a good vision, I would use an EDOF lens.
Okay, my view, I think, is close to yours. It depends from the size of the hole, obviously. So what you expect the visual rehabilitation to be. So if you're going to be using amniotic membrane because it's too big or whatever, obviously you're not going to be using an EDOF lens. But if you feel that the macular hole is small enough, it will close properly, then why not? And you feel that the vision will be good. Like all of you, I've had patients with macular holes that had 20/20. Now, why would you not want to put an EDOF lens there? I would personally do that. And I would do a sequential procedure. Why? Because I want to make sure that my focus is just on that problem. I will have the gas bubble in the eye, which could theoretically move the lens, dislodge the lens, because my patient is not positioning all the time. I could have more phlogistic reaction because I've done the cataract as well. And then I feel more at ease once everything is settled down, once I know that that thick retina has settled down, the hole has closed, then I can just take my time and give them the benefit of having a good cataract surgery with an EDOF lens. But again, it's beautiful to have these discussions because each one of us has a different approach. Patients are very different because no two patients are alike. Their clinical conditions are different. Their personal expectations are different. their financial conditions, which we tend to ignore as physicians because we focus just on clinical problems. But we have to remember these are real people, and real people have real problems. So they may have other issues, just not clinical issues. So having more takes on the same problem, and I think we have different views, and even within each group, the views change according to the certain condition. So I think this was very useful, and I thank you for the opportunity, and I hope it's useful for the audience as well. Thank you very much. Enjoy the rest of the meeting.